today for our endocrinology grand rounds, and we have with us one of our popular speakers, Betty Villafuerte. I don't have to say too much about her, just to mention that she graduated her medical school from the Philippines, did her endocrinology fellowship, and stayed on faculty at Emory before moving to University of Louisville in 2003. And she stayed here as full-time faculty until July of 2020. And since then, she's on gratis faculty, but moved to Owensboro. So her interests have been in diabetes, obesity, and also in a range of endocrine disorders. She has done both basic and clinical research. Of course, she was very passionate about a protein that she had identified, sensitin, and she worked on it for a long time. And today she's going to talk to us about adrenal hyperplasia and Cushing's disease, Cushing's syndrome. So, Betty?
Okay, thank you, Siri. Okay. Oh, okay. I had nothing to disclose. Hopefully, at the end of this talk, we have reviewed the endocrine conditions associated with adrenocortical hyperplasia, which I get referral now for a lot of adrenocortical hyperplasia. And to discuss the pathophysiology, clinical presentation, and management of unusual condition that leads to Cushing's disease, like micronodular bilateral adrenal hyperplasia and the macronodular hyperplasia, and to discuss just briefly, the genetics of micronodular adrenal hyperplasia and Carney complex. We usually start with a case. I think most of you have seen this patient because I sent her to Dr. Egger, and he's the one who did the adrenalectomy. She's a 34-year-old Caucasian female who was referred to me as a left adrenal adenoma. She said she never had regular menstrual cycle, but 4 years ago, she started bleeding 3 out of 4 weeks every month. She had a uterine ablation which did not work and had hysterectomy at that time. The reason she remembers that is her weight was 107 pounds after hysterectomy. Now she has difficulty losing weight despite exercise. She runs 3 to 5 miles a day, and now she weighs 140 pounds with BMI of 27.34. In addition, she's complaining that she feels awful, had headache every day, neck stiffness, low energy level, and photophobia. She also noticed increased facial hair growth, and she now had to have dermal ablation every week. And she's also losing a lot of scalp hair. She struggles to breathe. She can no longer run for 3 to 5 miles. 1 mile is so difficult for her now. She has difficulty climbing stairs. And on her Fitbit, the heart rate goes routinely to 120 per minute. So, and then furthermore, she was diagnosed with new onset hypertension in July of last year, and her initial blood pressure was 165/108. So she went to an internist here in Owensboro, who thought immediately of pheochromocytoma. He did 24-hour urine metanephrine, slightly elevated. 24-hour urine dopamine was also slightly elevated. Aldorenin ratio was not elevated. And he did a random serum cortisol, and it was 6.84 microgram per deciliter. His conclusion was the patient has pheochromocytoma. So the patient was sent to me at the same time that she was sent to Dr. Egger. So Dr. Egger actually saw the patient before I saw it. I was talking with Dr. Egger about another case. It's an adrenocortical carcinoma. And then he said, oh, by the way, did you see the so-and-so? I need you to see her because she's scheduled to have surgery in 2 weeks. I don't think she has pheochromocytoma. And then the lady had a CT scan. It showed left adrenal mass 2.7 by 2.1 by 2.1 centimeter. And the description was the mass is smoothly marginated and heterogeneous. Oh, don't mind to see me. The pre-contrast reading was 31 Hounsfield units, so it's pretty high. But there are some areas that's minus 17 Hounsfield units. With contrast, the 31 went up all the way to 91 Hounsfield units, and the washout was 37% in the bright area, the one that went to 91 Hounsfield units, and 70% in the fat area. So this is in the left adrenal gland. So I know I have very short time to work up this patient. We immediately did 1 milligram overnight dexamethasone suppression test, and her morning cortisol was 8.2 microgram per deciliter. Then 2 days later, I said proceed with that 8 milligram overnight dexamethasone suppression test. And her next morning cortisol was even higher than the 1 milligram. I said, now we have only the time to do one 24-hour urine collection, and the urine-free cortisol was not elevated. Her ACTH, which was repeated twice, was 5 to 7 picogram per ml. Total testosterone was low. DHEAS was low also. Androstenedione was lowest, So this is the actual reading of the CT scan, and they did mention that the right adrenal gland is normal. So keep that in mind that, what I'm going to eventually discuss is this is a bilateral disease. So she underwent left adrenalectomy, and then you guys discharged her on hydrocortisone 20 milligram BID. It took a whole month to get the pathology. I was puzzled because I keep on asking, maybe it's malignancy. That's why they're not giving me the pathology eventually. It turns out nobody can interpret her slides at UofL. So they send it to Mayo Clinic. And considering that one of the pathologists at Mayo Clinic was the first one who described this disease, nobody knows how to read the slides in Mayo Clinic either. So they sent the slide to Massachusetts General Hospital. So somebody did know how to interpret the slides, and the diagnosis was primary pigmented nodular adrenocortical disease.
Betty, will you take a couple of questions about the case?
Yeah, sure.
So was there a family history, or what were her pubertal milestones, and how tall was she?
She is about 5'2", so she's a small girl. Family history is very vague. A geneticist has traced all her family. There's a bunch of breast cancer. There's a bunch of colon cancer. Nobody has MEN1. Nobody has endocrine problem. It's all generic, cancer, and it's all late onset cancer. So they went through 3 generations of study, including the children, and there was no genetic,
And is the 5'2" very short in her family or average? Do you have any idea?
No. There's 2 sisters. She said they're all short.
Okay.
Yeah.
And was she taking antihypertensive drugs when the renin and aldo were measured?
No. Those were all before she was started on olmesartan by the internist. So all of them were done before, the medication. The initial workup was done by an internist, the 24-hour urine collection, etc.
Right. And there were no skin lesions, no doubt?
Oh, I will show you.
Very good. Thank
No,
you.
no obvious skin lesion, actually.
Okay, thank you.
So, just to review, Cushing syndrome is an unusual disease. It's not common. 13 cases per million individuals. Most of them are Cushing's disease or ACTH-dependent disease. 15% comes from ectopic ACTH, and 15% come from the adrenal gland. On the ACTH-independent Cushing syndrome or adrenal Cushing, 90% are due to unilateral tumors like adenomas and carcinoma. 60% are adenomas, 40% are carcinoma. Adrenocortical carcinoma, 60% are secretory syndrome, so they produce some sort of hormone, and 65% are mixed or pure cortisol secreting tumor. And part of the 1 to 2% actually of adrenal Cushing's come from PPNAD or primary pigmented nodular adrenocortical disease or ACTH-independent macronodular adrenal hyperplasia. So it's either micronodular or macronodular. So in this case, the patient has micronodular disease, primary pigmented micronodular disease. The way to distinguish the, source of adrenocortical hyperplasia is through measurement of ACTH to determine whether they are ACTH dependent or ACTH independent, okay? If they are ACTH independent, their ACTH is usually less than 5 picogram per ml, and usually it represents either the primary bilateral macronodular adrenal hyperplasia or the micronodular adrenal hyperplasia. There are 2 types of micronodular adrenal hyperplasia. The more common is primary pigmented nodular adrenocortical disease, which is the case that I just presented, or isolated micronodular adrenocortical disease. So there's no pigmentation, but the nodule size is less than 1 centimeter. Macronodular means the nodule sizes in the adrenal glands are more than 1 centimeter. And micro is less than 1 centimeter. So it's either pigmented or non-pigmented. With ACTH-dependent Cushing's, you either have the Cushing's disease or ectopic ACTH secretion, mostly related to carcinoid from MEN1, glucocorticoid resistance syndrome, and any of the congenital adrenal hyperplasia like 21-hydroxylase deficiency, 17-hydroxylase, all of them will present as adrenal hyperplasia. Or if they have normal plasma ACTH, we know now that most primary aldosteronism do not come from an adenoma. It's mostly secondary to idiopathic bilateral adrenal hyperplasia. We used to think of primary hyperaldo as usually coming from an adenoma. Now, there are data to suggest that most of them come from bilateral adrenal hyperplasia. Again, we're talking about bilateral diseases. Bilateral diseases that are ACTH independent. Again, it could be primary pigmented micronodular adrenocortical disease. It's a long name, PPNAD, or isolated micronodular disease without the pigmentation. In terms of the genetic defect, I'm just going to deal with it briefly right now, okay? For the macronodular hyperplasia, which is now becoming very common because of all the CT scan that is being done on the abdomen for trauma or any reason, now it is recognized that it's not as uncommon as we thought before. The most common genetic defect will be armadillo repeat consensus 5. The most common genetic defect for adrenal adenoma is the catalytic subunit of the protein kinase A. And the most common genetic defect for primary pigmented nodular adrenal hyperplasia would be the regulatory 1-alpha subunit of protein kinase A. So these are the three that may come out of, exam. In terms of radiology, you can see that this is a representation of bilateral adrenal nodules. You can see it here. Or if you have the primary pigmented micronodular adrenal hyperplasia, it may look like beadlets, little beads, a bunch of beads, or it can look almost normal. These are the macronodules of the adrenal gland. You can see one nodule. They're all really large, one, and one, and diffuse adrenal hyperplasia. So the CT scan data is also important in terms of determining the differential diagnosis. So what is PPNAD? The reason for saying that it's a pigmented micronodules is most of them are less than 4 millimeter in size. There's none not encapsulated, and it's sharply demarcated from the rest of the cortex. Sometimes the adrenal glands are normal in size. In terms of histology, the cells are actually pretty large and globular. They are eosinophilic, or they have clear cytoplasm. These are eosinophilic staining. And they contain coarsely granular brown pigment. They are actually lipofuscin. Lipofuscin is an end product of lipid oxidation. This is the reason why it's pigmented. It's because of lipofuscin. And they stain for synaptophysin. Synaptophysin is any neuroendocrine phenotype. The pathologists usually do this staining. We always read it in the pathology report. Rarely, this micronodular disease sometimes contain one nodule, one large nodule, which happened to this patient. She had a 2.7 centimeter macronodule that we thought, oh, it's just a regular adenoma. It's functional because it has a high Hounsfield units and, poor washout. And yet, it turns out that when they look at the section, it's a primary pigmented nodular adrenal disease. Okay. So, how does it usually present? Okay. Usually, there's early manifestation of this syndrome, the Cushing's. 50% of the patients are diagnosed with Cushing's by 15 years old. The youngest is 15 months old and 3 years old. And by adolescence, after adolescence, female preponderance occur. Before adolescence, it's equal between male and female. So by 40 years old, 70% of the women who are diagnosed with Cushing will be female rather than, male. So there is increased penetrance of the gene with increasing age in female. Okay? But it's nevertheless, the Cushing presentation is not so loud that, you diagnose the disease early. Most of the time, it takes years to manifest. In a series of 353 patients that was studied internationally, the median age of diagnosis was 34 years old. And it's more common in women, 71% compared to 29% in men, even though they have the same genetic mutation. Okay. And then the imaging may show normal or relatively atrophic adrenal glands or very small micronodules like the beadlets that I showed before. Usually they have higher urinary free cortisol and suppressed ACTH compared to adrenal adenoma that's caused Cushing's disease, or they have even higher urinary free cortisol than the macronodular hyperplasia disease. So what is the characteristics finding? If you do Lidl's test for Cushing, in which you use low-dose dexamethasone, do 24-hour urine collection, then do high-dose dexamethasone suppression test with that, 2 milligram every 6 hours, and then do 24-hour urine collection, what you will find is a paradoxical increase in urinary free cortisol with increasing dose of dexamethasone. I will show you why it happens later on. This condition is often familial and associated with either MEN1, Carney's complex. And to make the diagnosis, you require, genetic testing to see if the patient has mutation in the regulatory subunit of protein kinase A. The treatment of choice is bilateral adrenalectomy, but unilateral adrenalectomy has been successful in selected cases, particularly, like my patient, if the patient has asymmetric adrenal nodules. Again, on CT scan, you can either, most people use just normal CT scan. You see hypodense nodules or beadlets in a relatively atrophic adrenal cortex, or you get normal imaging, and or you do functional study. If you do scintigraphy, more than 50% present with asymmetrical uptake with macronodules, even though they're called primary pigmented, micronodular disease. Again, on the Liddell's test, instead of suppression of the 24-hour urine-free cortisol with successive use of the low dose and the high dose, instead you'll get a paradoxical increase in urine-free cortisol by 50 to 100%. This was reported in 69 to 75% of patients with Ppnad. This was a small group of studies. The reason for this paradoxical increase in urine-free cortisol is because the micronodules has glucocorticoid receptor overexpression. So if you use dexamethasone, you essentially is stimulating the cortisol secretion from the micronodules itself. So subsequent studies, larger series, showed only 48% will have this paradoxical increase in urine-free cortisol with this low-dose and high-dose Liddell's test. Any question? So to make the diagnosis, you still do what your usual Cushing's workup will be. You either do 2 urine-free cortisol measurement or 2 midnight salivary cortisol measurement or 1 milligram overnight dexamethasone suppression test or low-dose Liddell test, which is 0.5 milligram every 6 hours of dexamethasone, and then you check the cortisol level on day 3. After the initial diagnosis, the next step would be the differential. If you confirm that the patient has Cushing, then the next step would be to measure the ACTH level. If it's more than 15, you would assume that the patient has ACTH-dependent Cushing syndrome. And if the ACTH is less than 5 picogram per ml on at least 2 occasions, then you think of ACTH-independent Cushing syndrome, and then you do the imaging. Carney's complex. Carney's complex, when you have primary pigmented micronodular adrenal hyperplasia, you have to think whether this is part of Carney's complex. There are major criteria for, these are the major criteria to diagnose Carney's complex, and there are some minor criteria. You have to have at least 2 of the manifestation of the disease to diagnose Carney's complex. You either have, these are the major criteria. You either have spotty skin pigmentation with typical distribution around the lips, conjunctiva, inner and outer canthi, vaginal and penile mucosa, or you have myxoma, cutaneous and mucosal myxoma, or cardiac myxoma, breast myxomatous or fat-suppressed MRI findings on the breast, primary pigmented nodular adrenal disease, or paradoxical positive response of urinary free cortisol to dexamethasone administration during Liddle's test, or acromegaly. 10% of Carney complex have acromegaly due to growth hormone producing adenoma, or they can have Sertoli cell tumor, and it's usually calcified, and you can detect it by testicular ultrasonography, or they have thyroid cancer or multiple nodular goiter, or they have psammomatous melanotic schwannoma, blue nevus, epithelial blue nevus, breast ductal adenoma, and osteochondromyxoma. So supplemental criteria is if they have affected first-degree relative, or they have inactivation mutation of the protein kinase regulatory subunit of protein kinase A gene. So these are the criteria for Carney's complex. These are the minor criteria. It's very less specific, like intense freckling, blue nevus, cafe au lait macules, elevated IGF-1, cardiomyopathy, etc. Okay. Spotty skin pigmentation, otherwise named as lentigens, is occur in 65% of patients with Carney complex. You get cutaneous myxoma in 45% of the patient, cardiac myxoma in 72% of the patient, mammary myxoma 42%, testicular tumor 56%, schwannomas 5%, acromegaly 10%, and primary pigmented nodular adrenal hyperplasia only in 45%. So it's not as if everybody with Carney's complex will have Ppnad. Intense freckling, this is how it looks like. This is the lentigens, a lot of pigmented, nodule here, and blue nevus here. All my red-haired patient looks like this. I don't know. I must be missing a lot of Carney's complex before. Okay, so what is the inactivating mutation of the protein kinase A? It's a regulatory subunit. So the way it involves the cyclic AMP PK protein kinase A pathway. In the adrenal glands, the ACTH will bind to this 7 transmembrane domain of a receptor. This will lead to activation of the stimulatory subunit of G protein, which is a complex of alpha, beta, and gamma. Dissociate. It will then stimulate the adenylate cyclase. Okay. And adenylate cyclase will dephosphorylate ATP to cyclic AMP. Cyclic AMP will then bind to the inactive protein kinase A. Protein kinase A has 2 regulatory subunits and 2 catalytic subunits. When cyclic AMP binds to the regulatory subunit, this will dissociate the regulatory from the catalytic subunit. The catalytic subunit will go to the nucleus and act as a transcription factor, activating all the genes that are activated by cyclic AMP. In Carney complex, okay, the regulatory subunit of protein kinase A is mutated. Therefore, it does not bind to the catalytic subunit. So the catalytic subunit are free all the time. They can cause all this cyclic AMP induced transcription all the time. In addition, because they're not binding the catalytic subunit, there is increased synthesis of the catalytic subunit itself. So there's increased activation of this tumorogenic pathway. So again, the mutation is in the regulatory subunit of the protein kinase A, and when it mutated, usually truncation mutation, it's all inactivating mutation. What happened is now the catalytic subunit of the protein kinase A is free to activate the cyclic AMP pathway. In addition, it also affects the MAP kinase signaling pathway. So you also have ERK1 and 2 induced cell proliferation. It affects it indirectly. So you do not only activate the cyclic AMP PK protein kinase A pathway, but you also activate the MAP kinase pathway. And these are the most of the mutations has been identified in the exons of the gene. So these are all the known mutation. Each family has different mutation. So going back to this patient, okay, I look for every skin pigment that she has. She does not have the characteristic lentigens, So she had some freckles. She's a red-haired person, so she will have all this. I don't know what these are, but it almost looks like myxoma to me. Anyway, her echo was negative for cardiac myxoma, and her thyroid ultrasound was normal thyroid glands. There's no nodules, multinodular goiter, or no carcinoma. So I sent her to a geneticist who tested her for, she's negative for MEN1, she's negative for the regulatory subunit of protein kinase A, so there's no mutation there. I don't know why they add the tumor suppressor 53 at the same time, and she's negative for it. Now, I said that this is the major gene that is mutated. There is a negative regulatory pathway for protein kinase A, which is the phosphodiesterase enzyme. They will inactivate the cyclic AMP. Mutation of the phosphodiesterase has been reported to contribute to some of the pathology of the Carney's complex. So even though this is the main mutation that has been reported in most cases, now there are increasing evidence that the negative regulator could be mutated also, leading to increased cyclic AMP pathway activation. Okay. So, with the regulatory subunit mutation of the protein kinase A pathway, you can either have Carney complex or you can have just isolated Ppnad or micronodular hyperplasia with the same mutation. So just because you have this mutation does not mean you will necessarily have the Carney complex abnormality. You can have the same mutation and do not have any of the clinical manifestation of Carney's complex. Okay, now to all you guys' favorite topic, the macronodular adrenal hyperplasia. This is now increasingly recognized as a more common abnormality than the micronodular adrenal hyperplasia because of the, as I said, routine use of CT scan in trauma cases or anybody who come to the ER complaining of anything in the abdomen, they get a CT scan. So, adrenal enlargement that's caused by nodule size that are more than 1 centimeter. It can reach as high as 5 centimeter per nodule or even 10 to 12 centimeter in size. Majority of the cases have sporadic presentation with female preponderance. In familial cases, there's equal ratio between male and female. Only minority of cases present with overt Cushing syndrome. Most of them have subclinical Cushing syndrome. There are two types of macronodular adrenal hyperplasia. Either you have type 1 is that you have atrophic internodular cortex, or both the nodule itself and in between the nodule, they're all hyperplastic. And the way to characterize the cell, and this is the reason why the Cushing syndrome, when they have it, is very insidious, okay? They have two kinds of cell. The large clear cell or spongocyte, which express 3-beta hydroxysteroid dehydrogenase. And they have the compact cell, which express 17-hydroxylase, okay? Now, in the clear cells of the macronodular hyperplasia, you can only stain for 3-beta hydroxysteroid dehydrogenase. So, it's not efficiently converting the progesterone to 17-hydroxyprogesterone. The compact cells, you can only express 17-hydroxylase, which restrict the flow of cholesterol to, to delta-5 steroid, resulting in increased DHA secretion, or in our case, we measure DHEAS. So, the difference is, how do you distinguish it from cortisol-producing adenoma and ACTH-dependent adrenal hyperplasia? In both of these cases, you can stain for both 3-beta hydroxysteroid dehydrogenase and 17-hydroxylase in the same cell. Whereas in macronodular hyperplasia, you can only detect 3-beta hydroxysteroid in large clear cell, and you can only detect 17-hydroxylase in compact cells. So this is the way that is, at least at the pathology immunostaining level, that they distinguish it and confirm that this is a macronodular adrenal hyperplasia because of these two type of cells and two staining characteristics, immunostaining characteristics. Now, a significant proportion, 77 to 87% of macronodular adrenal hyperplasia involve activation of the cyclic AMP-PKA pathway by aberrantly expressed G protein-coupled receptors. So the problem is ACTH is not the primary regulator of this different G protein-coupled receptor. Remember the 7 transmembrane domain? Instead of ACTH being the primary regulator of the cyclic AMP pathway, as you would see in micronodule and adrenal hyperplasia, what happened is they have aberrant G protein coupled receptors. So most of the time their ligands are not ACTH. Their ligands could be glucose-dependent insulinotropic peptide or GIP, catecholamine, vasopressin receptor, serotonin receptor, angiotensin II receptor, or receptor for LH and HCG. For example, if the macronodules are overexpressing HCG, what happens is every time the patient becomes pregnant, they become Cushingoid. However, not every macronodules will have only one kind of aberrant receptor. 50% of patients will have multiple aberrant receptors, which may coexist in each patient. Lately, there's report that ACTH produced by the adrenal cells itself has been shown to lead to macronodular adrenal hyperplasia. So it's not coming from the pituitary gland. It's a paracrine effect also, but this is very little. 77 to 87% come from all these aberrant G-coupled receptor ligand that can be activated by other ligands other than ACTH. Okay, so it's usually is a benign condition with no reports of malignant transformation or metastasis. And the most common genetic defect is armadillo repeat containing 5. So it's just a DNA motif that you see in some gene, okay? It occurs in 40% of patients with overt Cushing and 11% in patients with subclinical Cushing. Okay, so this is the controversial part, the management of bilateral macronodular adrenal hyperplasia. Bilateral adrenalectomy is considered the treatment of choice for patients with overt Cushing's. But as I mentioned before, most of them have mild Cushing. So unilateral adrenalectomy has been advocated as a therapeutic approach for mild or subclinical Cushing because if you just remove one of the adrenal gland, you can have over 90% remission in clinic Cushing syndrome. And there is objective improvement in obesity, hypertension, and diabetes. In general, the urine-free cortisol level will normalize, but not the midnight cortisol level or the dexamethasone suppression test. You still cannot suppress the AM cortisol. In 1/3 of patients, they will have transient adrenal insufficiency if you remove one of the gland, even though the other gland is hypertrophic. You would think that it's producing enough cortisol, but turns out they still get adrenal insufficiency. The general advice is you remove the largest adrenal gland. And that side, or some people do not go by size alone, they do adrenal scintigraphy and see which one had the higher uptake and remove the side that has the higher uptake. Some people even do adrenal venous sampling to determine which side has to be removed. But the problem with this is in this case, you use epinephrine measurement to see if you're on the right vein, And if you do unilateral adrenalectomy, aside from more than a 90% remission rate in Cushing syndrome, the rate of recurrence of Cushing and the need for completion adrenalectomy is only 10 to 15% after 15 years. So most of the time you actually cure the patient. You escape the complications of bilateral adrenalectomy, in which on a 15-year follow-up study, that 38% of patients with bilateral adrenalectomies will experience on average one adrenal crisis per year. However, longer-term follow-up showed higher mortality in patients with unilateral adrenalectomy. A lot of times it's infection-related, whereas the patients with bilateral adrenalectomies have less death rate, mortality rate is lower. So that's the controversial part. Again, you have to measure, weigh between the frequency of adrenal crisis that occurs once a year versus the higher mortality if you leave one of the adrenal glands behind. And the complications are related to Cushing's because it's mostly infection. Again, the most common genetic defect for macronodular hyperplasia is the armadillo repeat, containing 5. So this actually is part of the WNT signaling pathway, the beta-catenin WNT signaling pathway. Nothing to do with the protein kinase A pathway. And the most common mutation for adrenal adenoma that leads to Cushing is actually the catalytic subunit of protein kinase A, whereas the most common genetic mutation for Ppnad is the regulatory 1-alpha subunit of protein kinase A. Even with macronodular adrenal hyperplasia, it could be part of the other syndrome like MEN1, hereditary leiomyomatosis, and renal cell carcinoma, or familial adenomatous polyposis. You can see that in MEN1, 20.4% have the macronodular adrenal hyperplasia, and 12.5% are bilateral. In this long syndrome, 7.8% has adrenal involvement and 15% are bilateral. In familial adenomatous polyposis, 16% have adrenal involvement and 23% are bilateral. In contrast, McCune-Albright syndrome involved the mutation of the alpha stimulatory subunit of the G protein complex, okay? And now we know that in the, protein kinase A, that's micronodular adrenal hyperplasia, or you can have mutation in the phosphodiesterase, enzyme, which inhibit the cyclic AMP, whereas in macronodular hyperplasia, it's mostly because of the aberrant receptor in the adrenal glands that lead to macronodular adrenal hyperplasia. In Carney complex and isolated PPNAD is the regulatory subunit of the protein kinase A. So how do you compare these two syndromes, the micronodular versus macronodular? On average, the average age for onset of the disease is earlier in micronodular hyperplasia compared to macronodular, which is 50 years, and there is a slight male predominance, okay? Both of them have elevated plasma cortisol with loss of diurnal variation. The Cushing's with micronodular adrenal hyperplasia is more overt compared to macronodular, in which most of them are subclinical Cushing. Okay, and there is that paradoxical increase in urine-free cortisol with the Lidl's test using if the patient has micronodular adrenal hyperplasia, whereas you do not have that problem with macronodular hyperplasia. In both cases, of course, they have normal pituitary sella and fossa. And in terms of, they have either adrenal hyperplasia, unilateral or bilateral, or they have normal adrenal gland size. Whereas with macronodular, you see overtly large macronodules, which is 0.5 to 5.3 centimeter in sizes. With micronodular adrenal hyperplasia, 50% of the cases are familial and associated with Carney's complex. So not everybody have Carney's complex. That's what I hope my patient has, because she spent a lot of time taking picture on all the parts of her 4 children to make sure that they don't have lentigens. Again, these are uncommon causes of Cushing syndrome. You either have the macronodular or micronodular adrenal hyperplasia. They constitute about 1 to 2% of Cushing syndrome. And PPND could be just adrenal defect, or it could be part of Carney's complex. And the common mutation is you have this regulatory subunit of protein kinase A that are mutated in micronodular hyperplasia versus the armadillo arm repeat containing 5 in macronodular hyperplasia. It's not clear why this mutation lead to all those aberrant G protein receptor, The differential diagnosis, of course, includes, Cushing's disease that can lead to constant stimulation of the adrenal gland, or ectopic ACTH secretion, glucocorticoid resistance syndrome, and all the congenital adrenal hyperplasia. This concludes my talk. I hope somebody understands it. It's a little confusing. Any question?
Well, I found it very thorough and informative, so thank you for doing it. So do you plan to test the first-degree relatives with, measure their ACTH and do a dexamethasone suppression test? I mean, the Carney complex, because you can have very severe osteoporosis from
Yes,
lifelong glucocorticoid. And also the heart problems, the myxomas can result in strokes and other
yes.
terrible things. So you certainly don't want to miss that.
No,
I don't think the skin lesions are that definitive, and I wouldn't trust screening by skin lesions. I would
I
do the
did I did an echo to look for atrial myxoma, cardiac myxoma. She was negative for it,
I'm
you
talking
know.
about her first degree relatives.
Oh, okay. Yeah, she has 4 children. I
Oh, I thought she was always infertile.
No. She has 4 children. Before she had hysterectomy 4 years ago.
Oh, I
She
missed
had
that.
irregular menses, but she had 4 children already.
Ah,
And I told you she keep on taking picture for every skin pigmentation, looking at
no,
them.
but I wouldn't count on that. I would be much more aggressive because it's a very bad disease to have. You
But she
know,
tested negative for mutation of the regulatory subunit of
yeah.
protein kinase A.
Well, did they sequence it or did they look for just candidate mutations?
I don't know what, the Ambry genetic
Yeah,
company do that.
yeah, because there's all sorts of strange mutations just in the regulatory subunit, and just because she didn't have the major one doesn't mean she
Uh-huh.
didn't have one of the minor ones. And like I said, the disease is very bad.
I know,
So
I know.
Yeah.
Dr.
I
Dr.
would be more
Villafuerte.
aggressive. I would be
Yes,
more aggressive and look for ACTH levels and a DEX suppression test in
yeah.
every first degree relative.
Actually, my first decision would be whether the other adrenal gland has to be taken out.
Well, that too. Yeah, absolutely.
But every time I try to withdraw her from the hydrocortisone, she keep on going into adrenal crisis. So
Oh,
more
well,
likely, the other side is not involved.
yeah, that's true. That's another issue. But I'm just bringing up the issue of all first degree relatives.
Yeah, yeah. So far, since she does not have all the major criteria for Carney's complex, it's hard to, screen the rest of the family.
Well, it's up to
Dr.
you.
Reed, would you biopsy the lip myxoma? Because it does look like a myxoma. By the way, great talk. Loved it. Very comprehensive. This is Swapna.
It's
Would you want to biopsy the lip?
Yes, probably. That's what I have to do now. Yeah, so she's not from Owensboro. She's from Evansville. So she has to drive a long way to come and see me. But she comes regularly, so I will send, the lip thing
I mean,
is the
that would be
only thing.
informative to
Yes,
make
yes.
further decisions
Yeah, that would be helpful, really.
and fairly easy to do. I mean, not,
Yeah,
minimally invasive.
right. It's just I never expected to see this kind of cases, but I get the whole town have Cushing. What can I say? You know, They're just waiting for me to move to Owensboro to come. I have Adrenocortical. I send everybody to UofL because they're
They
very,
get all the diagnosis done. So, but thank you for the
yeah.
case.
Because they're all diagnosing Cushing based on random cortisol level. I don't know why.
Yeah.
Maybe they don't know enough.
Yeah. So I have 6 cases already. But
That's pretty good.
okay. Anything else? Any other question? What about
Well,
the mass nodular hyperplasia argument? Dr. Winter wants to leave them alone.
Dr. Villafuerte, that was a very nice talk. I'm in Las Vegas visiting one of our daughters, so I'm very glad to be able to hear this, you see. It's an advantage over coming downtown. But what I'm wondering about, you read a lot about the effect of the SARS-CoV epidemic on medical care, and here you can see two teaching hospitals that could not read the slides at the time. So
Yes. I'm so
that,
surprised Mayo Clinic cannot read it. Carney's complex was first described by their pathologists. You know, so they send it to Mayo. You know.
yeah, but it's so it kind of shows, again, you read the effect of the epidemic on other portions of medical care.
Really? Yeah. I thought at first I called pathology at UofL and said, "What's wrong? Is it cancer? How come it's taking a long time to get the slides in?" They told me, they have problem. Nobody knows what it is.
Thank you.
You're welcome. Thank you. Any other question? No? Everybody went to sleep. That's the problem.
Okay. Hey, Benny,
Not
there are a
hardly.
couple of questions here on the chat. One question is, if you choose to proceed with unilateral adrenalectomy, would you do adrenal venous sampling to decide which?
We thought we're dealing with adenoma, Cushing's from adenoma, because she had that 2.7 centimeter nodule on the, adrenal gland. So we thought the, pathology is, but
just unilateral.
yes. So, however, the adrenal venous sampling is actually harder than for hyperaldosteronism because you actually have to measure the epinephrine to see if it's, in the right adrenal vein. I don't know why epinephrine is being used as a standard to do the adrenal vein sampling. I would think that, adrenal scintigraphy would be easier. If you do the, iodocholesterol NP something scanning of the adrenal glands, and you see that this is done for macronodular hyperplasia to see which side is more functional, and that's the side that's taken out sometimes. It's hard to tell. I keep on scratching my head. Do I remove the other side? But, so far she goes to church, she comes back in adrenal crisis.
Yeah, I'd agree with Betty. I mean, what I've learned about it, and I also talked with Jim Finley once about it, and he felt just like that, is that the adrenal venous sampling is very uninformative and can be confusing. So either use the scanning or just take out the bigger adrenal based on the anatomical size. And see what happens.
Yeah, but remember, if you in macronodular hyperplasia, it's just one series, okay? It's over 300 patients. They found higher incidence of mortality after 15 years in people who had unilateral adrenalectomy. And it's Cushing related, because if you don't monitor it closely enough or the patient is lost to follow up, then you won't know when to remove the other adrenal glands, which happen in 10 to 15% of the patient only. But you're right, it's unilateral adrenalectomy that's being advised, All right, thank you very much.
Thank you very much. So we'll meet again next week. Thanks.
Okay, see you. Okay.